Hello, 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 everyone, and welcome to the Dr. Tamar Beckford Show. I am excited because today we're going to be talking about sleep. Now, we all know we need it. We all run away from it and act like we can be productive without it, which is false, right? So people say, oh, I don't need sleep. Okay, well, today we have an expert that's going to let you know what are the top 5 things all doctors need to know about sleep. And if you aren't a doctor, you need to listen because you've probably been there saying, like, I'm good until you're not good, right? Alrighty, let me bring on our wonderful doc in our wonderful fashion. Alrighty, so our doc. She's a graduate of the University College Cork School of Medicine. She did her residency in psychiatry at Henry Ford Health System. Then she did a fellowship in sleep medicine. So now you understand why we're going to dive into this. So you're not getting just some surface info. So she did her fellowship in sleep medicine at Harvard Medical School. She's the founder and medical director of Pacific Integrative Psychiatry, where she has this very wonderful, extensive online practice in California. Her patients receive a whole person approach to anxiety, depression, and sleep disorders, including nutritional, psychotherapy, and integrative and functional medicine approach, right? So she's dealing with the whole person, right? In addition to that, she's also the founder of IntraBalance, which is an educational platform for physicians and therapists. It includes a YouTube channel, it includes online courses on clinical sleep medicine for healthcare practitioners. Her passion is simple. It's really simple. She's like, listen, we're going to make clinical sleep medicine easy to understand and accessible to all, right? Who am I talking about? I'm talking about the one and only Dr. Nishi Bhopal. Woo! Hello, 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 Dr. Nishi. How are you?
Hello, thank you so much for having me, and thank you for that amazing introduction. Yeah, no, I'm so pleased to be here and super excited to have this conversation about one of my favorite topics, which is sleep.
Sleep, right? Sleep. We all need it. Alrighty. So before we go diving deep into the sleep portion, let's get to know you a little bit better. For those who have not been in Dr. Nishi Bhopal's world and they don't understand why you're so passionate about it, let's start with what made you decide to be a doctor in the first place? Like, where did that come from, Dr. Nishi?
Yeah, no, it's such a great question, and like it's an interesting thing because I grew up in an Indian family
Mm-hmm.
in Canada. So I was born in Canada. That's where I grew up.
Mm-hmm.
Lived in Scotland for a few years as a child, but mostly was raised in Canada. And in many of us who grew up in Indian families, or maybe
Mm-hmm.
even like other ethnicities, there's
Mm-hmm.
this idea that you're either a doctor, lawyer, or engineer
Right.
when you grow up, right? So this idea of being a doctor, it was like kind of this like seed that was planted at a very young age. And I used to hear when I was growing up, when you're a doctor, you'll be able to do this. Oh, when you become a doctor, you'll be able to X, Y, Z, all this stuff. So that idea was there. So it was partially like, subliminal programming, maybe. My father's also right. Yeah. And my dad's a physician. He was a GP for many years. Then
Mm-hmm.
he became a psychiatrist. Now he's retired. So I was always exposed to
Mm-hmm.
medicine. So for me, it was always this thing that, yeah, I could do that. And that sounds really interesting. But I don't think I was like the traditional sort of pre-med student where I had this idea
Mm-hmm.
that I have this passion to become a doctor because I was really interested in everything when I was growing up.
Ah.
I loved everything. I thought I was going to be a fashion designer. I thought I was going to be an interior designer. I thought I was going to be an English literature professor. Like I had all these ideas of what I wanted to do, and I loved all of it. And
Mm-hmm.
even when I was in university, doing my undergrad degree, I did that at UBC, at University of British Columbia. I kind of studied everything. I studied, all my pre-med courses, so your biology courses, your, organic chem, all that stuff. But I
Mm-hmm.
studied literature, I studied anthropology,
Mm.
South Asian history, all this stuff. And I remember one of my professors was like, "You are here for an education." He's like, usually people have one track that they're on, and I was like, I love all of it.
I
So
love that. He was like,
yeah.
he's there looking at your transcript like, oh, you've been through all of the studies. Oh, the humanities? Oh, the sciences, the social sciences? Oh, wow.
Yeah, yeah, all of it. I was taking Hindi, I was taking French, like all these language classes. So then it came to this point of like, okay, now I have to figure out a career, like I
Hmm.
need to make a decision. And then, I kept going back to that idea of, well, you could become a physician. My dad was like, psychiatry is really, it does blend in the humanities. There's a lot you can
That's
do with
true.
that. So I thought, okay, so I ended up going to med school. So like I said, it wasn't that
Hmm.
traditional, like, oh, I have this passion for medicine. I do love it. I enjoy it, and I found ways to really love it. But
Hmm.
I know, we'll talk a little bit about burnout too, but there was always this thing of like, but could I be doing something else? Should I be doing something else?
Hmm.
So, but yeah, that's in a nutshell how I ended up going into medicine.
I love it. So you were a lover of learning, period. The lover of wanting to know about all the things that goes into not just science. So, you were already, the seed was planted that, okay, Nishi, when you're a doctor, Nishi, when you're a doctor, you're like, okay, okay, okay. But then you found that you had this passion for life itself. That's what it sounds like. So life as just not in the sciences or the traditional sciences, but like humanities, languages, just the breadth of learning to really learn. So your undergraduate was an experience in depth of just really exploring all that there is. It was also almost like the traditional, the Socrates. Okay, we're gonna go off to just learn for the sake of learning. Not that I'm zoned in and getting all my prereqs and all of my things, and I'm like, okay, thank you so much for this degree, so I can apply to medical school. Like you really wanted to be a part of the learning experience. Alrighty, so you did that, then you had to make that decision. So the decision, including understanding and including the seed that was planted, but also the breadth of info that your dad says, hey, you can also use this in clinical medicine. You decided, okay, I'm going to med school. So you're in med school, you decide psychiatry. Was that what you initially went in thinking? Or did you land upon it like some of us land upon our specialties?
Yeah. So, okay. So I went into med school actually thinking I was going to be a pediatrician.
Ah.
That was the image I had in my mind. I always loved children. And I thought,
Mm-hmm.
oh, that would be so great, to help children and become a pediatrician. So
Mm-hmm.
that's what I intended. And then when I went through med school, as many of us do, you start doing rotations in
Mm-hmm.
different specialties. And then I realized peds actually isn't for me. But I ended up choosing internal medicine because,
Ah,
again, going back to this idea of I didn't
breath.
want to pigeonhole myself. Yeah, the breadth. I thought, okay, internal medicine, you get to work with all kinds of conditions. There's
Mm-hmm.
a lot there. You can specialize in any number of, different subspecialties. So I ended up choosing internal medicine, although I still had that interest in psychiatry that was always there. So by the time I got to applying for the match, I
Mm-hmm.
was had this question in my mind: should I apply for IM residencies or should I apply for psych? And
Mm-hmm.
I ended up choosing IM. So, if anyone is listening, if they're in med school and you're trying to decide on your specialty, you may be going through this dilemma in your mind of what do
Yes.
I choose? So my story is I ended up choosing IM for the match.
Mm-hmm.
I
Mm-hmm.
matched into an IM program at Henry Ford Hospital,
Mm-hmm.
and I went through my IM intern year, and I just found myself talking to my patients about their mental health, their well-being, what's going on in your lives. Do you like your job? Tell me about your family dynamics. All of these questions that we really didn't have time to dive into during
Mm-hmm.
an internal medicine clinical visit.
Yes.
And that's where it started to become very clear to me that psychiatry is probably going to be a better fit.
Mm-hmm.
So I ended up switching from IM into psych after my intern year. And I actually reapplied for the match
Mm-hmm.
to go into psychiatry residency. And then it just so happened that before the next year started, before second year started, the program director at Henry Ford, the psych program director, called me and she said, hey, someone just dropped out for next year. We have a spot for you. Do you want it?
Oh,
And I said, yes.
yes.
So that's how I went into psychiatry.
Love it. Love it. So psychiatry called you. You were there ignoring the call. Psychiatry called you. You said, "Oh, I'll test out internal medicine." And you use all your psychiatric skills in internal medicine, which is not happening. So, but the thing that I love about this journey, although it's hard, I know we're looking at this now from this standpoint, but I know it's challenging during the time you're going through it. Is that you got the chance now to not to have no doubt in your mind if psychiatry is for you, because you did the residency in the internal medicine. You did that year, which would be all like a prelim year. It's kind of like you did your prelim year, but it gave you the breadth of to use that breadth of knowledge that you wanted to, but also gave you the understanding that my calling really is to be able to integrate this person in a biopsychosocial manner, which sometimes you don't get as much of the time to do that in internal medicine. And that's why we rely on our colleagues in psychiatry. Alrighty, so now you're in psychiatry and you're like, yay, I'm here. But then you didn't even stop there. You started going for fellowship in sleep medicine. So was a psychiatry enough? Come on, tell us what made you decide to go into sleep medicine.
Well, for lifelong learners, it's never
Yes,
enough, right?
that's so true.
We just don't stop. Can't stop, won't stop. So,
Exactly.
so sleep medicine, that was actually not something that I was aware of. I didn't know
Mhm.
back then. Now it's gaining more traction, but back
Yes.
then, so we're talking, 10, 11 years. Oh my gosh, is it even longer than that now? Maybe. Yeah. We won't go there. But, back then, sleep medicine wasn't as popular as it is now, and I didn't
Mhm.
even know that it was a specialty that you could do.
Right.
And when I was in IM, actually, one of my senior residents in internal medicine was going into a sleep medicine fellowship after her
Mhm.
residency. So that's the first time I actually had heard of it.
Mhm.
And so that just piqued my curiosity. And I asked her, "Oh, well, tell me about that. What is that about?"
Yeah.
Yeah. And she told me that where we were training at Henry Ford, they had a great sleep center. And she
Mhm.
said, "You should contact them and see if you can do rotations." And so I did that. And so I started doing rotations with them while I was in my psych residency. And
Mhm.
I became so fascinated by it because there is such a relationship, bidirectional relationship between mental health, of course,
Mhm.
and physical health too, and sleep issues.
Yes.
And in my psych residency, I was seeing all these patients who were struggling with sleep, and I felt like I
Mhm.
wasn't learning enough about how to really support them outside of using medications.
Mhm.
And so that's how I got interested in sleep medicine. Plus, I had my own personal motivations as someone who has always struggled with fatigue and being sleepier than my
Mhm.
peers, and not knowing how to get a handle on that.
Right.
So, so that's kind of how I got interested in that. And then I ended up applying for a fellowship and completed my fellowship in sleep medicine.
Okay, I love it. So now we're there and we've recognized the importance of sleep. And as you said, over the last 10 years, it's now becoming more in the forefront when people think about the health overall. Before it was a thing they said, well, I'll sleep when I'm dead. And then now it's like, well, if you don't sleep, you'll die. It's the opposite. So, what are some of the top 5 things that all doctors need to know about sleep? Because a lot of us are now just realizing, like, wow, this thing is really important. And we didn't really get that much of it during residency because that's when you don't sleep. so, so, tell us a little bit more about that.
Yeah, absolutely. And I'm so glad you just highlighted that because the statistics show that the average doctor gets
Mhm.
about 2 hours of sleep education during their training, which is kind of
Mm.
astounding because
Yes,
name a patient of yours who doesn't need to sleep, right? Like every single patient needs to sleep. But, we're just not getting
absolutely.
enough. Yeah, and, in some schools, there's 0 hours of education in sleep.
Mhm.
So, I'm
Mhm.
I'm really glad that you highlighted that. So, the top 5 things every doctor needs to know about sleep. So, number 1 is that insomnia isn't always insomnia. So, if you have a patient coming to you complaining of insomnia,
Mm.
you need to look under the hood to see what is actually going on. And I've seen this time and again where the patient in their experience, it feels like insomnia because they're having trouble falling asleep or staying asleep. But that could actually mean they have a circadian rhythm misalignment. It could mean they have sleep apnea. It could mean they have restless leg syndrome.
And
Maybe there's
absolutely
something else, right? So we need to kind of
issues.
not take it at face value.
Mm-hmm. Sorry about those who are watching. I'm having some low connectivity issues here, but hopefully we do not lose any connectivity at all. But we're saying that number one, overall physicians in our training, we have gotten as little as zero amount of training on sleep, and some even as maximum on just the regular training as 2 hours of training. But we definitely recognize the importance of it. But we all have patients who need to sleep. 100% of our patients need sleep. And it's important for us to understand, sleep and its role. And there are a lot of times that we have our patients who are coming in and they're saying that I have insomnia, but insomnia might not truly be insomnia. So you were letting us know a little bit more about that. So continue, Dr. Nishi.
Yeah, absolutely. Thank you. Yeah. And I apologize if the connectivity issues are on my end. I'm not sure, but
no worries.
Yeah. So the idea here is not to take insomnia at face value. So that's tip number one, because it could be a sign of an underlying sleep disorder, like a circadian rhythm issue, obstructive sleep apnea, restless leg syndrome, or any other number of conditions. And, I'm thinking of patients that I've seen where they were prescribed a sleep aid by their physician, and no fault of the physicians, right? Because we don't have the education and training on this, right? So you do the best that you can with the knowledge that you have.
Absolutely.
But I see this time and again where patients will come to me and they've been prescribed Ambien or some other type of sleep aid, and they didn't even have insomnia. And we figured out that, oh, actually you have a delayed circadian phase and you don't need sleep aids. And that's highly treatable without prescriptions. Or maybe they had sleep apnea. And I see this in women a lot because sleep apnea shows up differently in women than it does in men. And it will not show up with the classic thick necks, snoring, waking up with gasping arousals. It can look like depression, fatigue, fibromyalgia, aches and pains, general malaise, right? So we need to be just kind of peeling back the layers a little bit to see what else might be going on.
That is very fascinating. A lot of times when we think about, like we said, sleep apnea, we are thinking of those traditional things. So a person who is thin, has a thin neck, and they're saying I have sleep apnea, well, I'm having problems sleeping, I should say. Sleep apnea is not something that comes in mind, especially when we think about females. So this is interesting knowing that sleep issues, when it even relates to the male versus the female, it's some of these presentations are so different. And so, like we said, insomnia might not be insomnia. There could be layers that's causing this. So, alrighty, I love that. So now think about, your patients that are coming in with the generalized aches and pain and chronic fatigue and, saying like, okay, I have fibromyalgia. Like, wow, this could really be an issue related to sleep. Interesting. Alrighty. What's another thing that we have not even been thinking about?
Yeah. Okay, great. So that was point number one. Point number two is that sleep issues are highly treatable. Okay. So there is hope. So I see this a lot in physician Facebook groups where physicians are like, oh my gosh, I'm so frustrated with managing insomnia. I'm trying all these different medications with my patient and it's not working and I don't know what to do next. And, the physicians are frustrated, the patients are frustrated, and then it just creates this loop of trying one med after the next and nothing's working. So the thing for physicians to keep in mind is that sleep issues are highly treatable with the right approach. So it starts by figuring out the right diagnosis, as we were just talking about, but also just starting to learn some basic CBTI or cognitive behavioral therapy for insomnia principles that everyone can use in your clinical practice, even if you only have a couple of minutes. This is something I teach on my YouTube channel and in my program, but specifically, learning how to do a little bit of sleep compression or sleep restriction with your patients, and
Mm-hmm.
then teaching them about circadian rhythm regulation. Those two little behavioral tweaks can go a long way. And it's not just sleep hygiene. These are specific techniques that you can use with patients. And then also in this category of sleep issues are highly treatable is knowing that there's a whole array of practitioners who are specialized in sleep that are
Mm-hmm.
available to work with your patients, right?
Mm-hmm.
So there's therapists, there's sleep doctors, but now there's a whole world of sleep coaches as well.
Yes.
So really taking advantage of what's out there, and with telemedicine, these
Mm-hmm.
services are a lot more accessible than they used to be.
Absolutely. And just that alone will bring a lot of ease to someone's mind. When you think about having a condition, the first thing that goes to your mind is, okay, oh my gosh, I wonder if this is treatable, or am I just stuck with this condition? So to just hear that, oh, this is a treatable condition. There are different modalities that are out there in order to help you to overcome what is the underlying issue that's causing this sleep abnormality that you're having, because we know that a lack of sleep causes so many things in someone's lives. And even when you talked about restless legs, I have had so many patients who are on restless legs meds. And if I really sit and think about it, I work nights. So they're coming in the middle of the night, and yeah, they won't get sleep if they keep waking up, because they're just continuously having these restless leg symptoms. So just even knowing that things are available, that's one of the underlying cause that you mentioned for a lack of sleep. And then knowing that we have not just those who have specialized in sleep as doctors, as coaches, and therapists. So with the line of therapists and coaches, that you have the ability to have care throughout the either here in the US or even internationally, because now it's such a big priority that we're keeping that to the forefront of our mind. So it's treatable. Woo, feels good. We're not stuck. Love it.
There is hope.
There's hope. All righty. So what is the next thing that, we just really need to keep in mind as physicians?
Yes. Okay. So number 3 is don't forget about a lab workup, because
Mm,
this is another thing that I see a lot happening. And again, no fault of the physicians. It's just, we're just not trained in this stuff. But
mhm.
again, it goes back to that point number 1 of insomnia isn't always insomnia. So we
Yes.
need to look under the hood, and just some basic blood work can give
Mhm,
you a lot of information. So just doing, an iron level, right? You're talking about
mhm,
restless leg syndrome. So
mhm,
you might find out that the patient has a subclinical iron deficiency anemia. Maybe their
mhm,
ferritin is less than 75, right?
mhm,
That can also contribute to restless sleep, not just restless leg. So
mhm,
looking at things like this, I pick up on a lot of subclinical vitamin D deficiencies or insufficiencies, B12
mhm.
deficiencies and insufficiencies. And it sounds really simple, but I've seen this time and again in my clinical practice, where if we start optimizing those levels with patients, their sleep quality starts to improve, and
Yes.
their daytime energy levels start to improve, their cognition improves, their mood improves. These are basic things that are often missed. So don't
Yes.
forget about doing labs.
Wow. Basic, iron deficiency and vitamin deficiency are not things that I would pair with insomnia or sleep disturbances. I mean, I would say, okay, maybe you are tired because you're deficient, but I would not think that fatigue would cause you to not be able to sleep.
Mhm.
Wow. And like you're saying, these are just really very small clinical acumens, number one, and lab work that can be done that can help to dive deeper into why someone might be having the sleep issues. So we have someone that's saying hello to us, CL King. Hello, CL King. Thank you so much for joining us today on this. I hope you're enjoying this wonderful topic as much as I am. So, okay, so vitamin B12 deficiency. And then, so now when we even think about that, there are so many people who have had, you know, now it's making me think of those who might have had surgeries. So we've had those who've had bariatric surgery, and at times they end up being, a little bit deficient in their sleep. Well, not their sleep, but in their vitamin deficiency if you're not keeping up with these special vitamins. So, but a lot of times I don't think that we've thought that, okay, maybe the surgery will help with the sleep, but if you're not having an improvement with the sleep, then there's now another avenue for one to think about.
Yes, absolutely. And so these are things to, yeah, exactly. So things to start thinking about, so if your patients had bariatric surgery, or maybe they're on a medication that depletes, so I'm
Hmm.
thinking about patients who are on PPIs, right? Proton pump
Right.
inhibitors. They might be depleted in magnesium, right?
Yes.
So that, of course, can impact their sleep quality and their energy levels. Patients who are taking beta blockers
Hmm.
can deplete the melatonin levels.
Hmm.
So there may be a scope for supplementing with melatonin, right? So just thinking about these biological factors, sleep,
Hmm.
of course, is largely like with insomnia specifically,
Yes.
there's largely a behavioral component to it, but there's also these underlying biological factors that can have an impact. And, even with these vitamins that we're talking about, vitamin B12, vitamin D, they also affect the circadian rhythm, right? So these
Mm.
are, so if you think about like all the cofactors that are involved in synthesizing, serotonin and dopamine and acetylcholine and all of these things, these vitamins are those cofactors. And so they
Yeah.
have downstream impacts on the circadian system and sleep regulation.
I know. So we have this Dr. Sarah Nasir. She's like, oh, this is such a great topic and it's very insightful. And yes, she has the same wow with the beta blockers depleted melatonin. How interesting. Did not know that. And how many patients do we have on beta blockers? Many, many patients. So now we're thinking about those who are on beta blockers for their high blood pressure, and they're saying they're having sleep issues. And we're like, well, maybe your pressure is too high, or maybe your
Right.
pressure is too low. But wow, what about thinking, okay, maybe the melatonin level and just something as simple as, like you said, supplementing with melatonin can probably have such a great effect on someone's sleep quality. Very, very, very interesting.
Yes. And
Alrighty.
I'll make one more connection there too with the beta blocker
Yes.
and sleep, which
Hmm.
is that so if your patient is on a beta blocker for hypertension, right?
Hmm.
Why does your patient have hypertension? Do they have untreated sleep apnea, right? So
Hmm.
I'm always on the lookout for that too with patients who have hypertension or they have treatment resistant hypertension. It's not
Yes.
something that I'm a psychiatrist, so I'm not treating their hypertension, but it's a flag in my mind, right?
Absolutely.
So again, the beta blockers can cause melatonin depletion, but why are they on the beta blocker?
In the
And
first place.
is there something else going on with regard to sleep disordered breathing to be on the lookout for?
Absolutely. Absolutely. Love it. Love it. Love it. So now we're on all those well, the vitamins and the nutrients, the magnesium levels, keeping that in mind, vitamin levels, vitamin D, B12, so many, many patients that one can think about that are having these issues. Alrighty, go ahead. What is our next thing that we are just like, oh, wow, just overlooking because we just aren't thinking that these could be some of the underlying causes because we're looking for like the big things, but they're also very small portions that can have big impact on someone's sleep and their quality of life. Go ahead.
Yes, absolutely. And so, yeah, and that's something that I go into more detail with inside my program for physicians, like where we go, we take a deep dive into these factors so
Mm-hmm.
that you can know exactly what to start looking for, right?
Yes.
Okay, so point number 4 is to use a framework that I call the CSH framework. So
Mm-hmm.
anytime a patient is coming to you with sleep issues, and again, I know it's really overwhelming if you're not a sleep doc. Like, even for me as a psychiatrist, if a patient comes to me, usually they're coming for anxiety or depression or something like that.
Mm-hmm.
More often than not, there's some sleep disturbance going on with that. And you might not have time to go deep into the sleep issue in that visit, right? Because there's so many
Right.
other things we need to do in a patient visit. So here's what I recommend to every doctor to do in your patient visit is to use the CSH framework that I use. C stands for circadian rhythm,
Mm-hmm.
S stands for sleep drive, and H stands for hyperarousal. Okay, so how you use this is you just have this framework in your mind as you're assessing their sleep issues. So patient comes to you and says, I can't sleep, or I'm not getting good sleep. All right, let's talk about their circadian rhythm. Tell me about your daily routine. What time do you get up? What time do you go to bed? What's your schedule? What's your light exposure like during the day? What's your darkness exposure like during the night? If you don't have time to go into all of that, you can even just have them fill out a questionnaire before the visit, right? And that's a way for you to get that information. Sleep drive, that's all about, your activity levels during the day, minimizing naps, which are like a snack before dinner, right? If you're having a big snack, you're not going to be hungry for dinner. A nap is like that. It's like a big snack. You're not going to be hungry for sleep at night. So assessing their sleep drive, their caffeine use, which also impacts sleep drive. And then the H stands for hyperarousal. So this is a larger category that includes their stress levels, nervous system activation, and then any other medical conditions that could be contributing. So we were talking about hypertension, maybe there's metabolic issues, hypoglycemia, blood sugar fluctuations, maybe there's depression, anxiety. All of these things fall into that hyperarousal category. So it's just a way for you to systematically work through the sleep issues, because sleep issues often feel very murky. When a patient comes to you and they're like, I can't sleep. And you're like, oh my God, where do I start with this?
Where do I even start?
Right.
Have you tried?
Right. Yeah.
Yes. I love it. When someone, you're right, because even as an ER doc, patients come in and like I said, I work in the middle of the night. So what are they coming in saying? I'm having insomnia. And I'm like, okay. And I'm thinking, insomnia is something that's causing this person a huge effect on their life, but it's not a medical emergency. And I'm an ER doc. So now how can I think about this? And what do I have in my arsenal to help this person with my limited sleep training that I got in med school and the limited sleep training that I got in emergency medicine training? And it's really like, well, have you tried sleep hygiene? Have you done this? So my thing is like, have you listened? I'm like, this is what I listen to. Do you want to listen to this too? So that's my arsenal. So now thinking about this framework, asking them, well, what time are you going to bed? Like, what are you doing during the day? And you said their light exposure. So are you jumping on your phone because you can't sleep? And then, ordering things from Amazon? Not saying that this has happened before for me, but this just might be some things that happen at 2 a.m. in the morning.
Hypothetically speaking.
Packages arrive afterwards. But you're right. What are we doing? And then the stimulants, are you having a lot of caffeine? Are you, like you said, are there medications? Are you doing the nap snack where you're having this instead of like 15, 20 minutes, you're having a 2 hours, and then you're not going to be able to sleep, right? Because you've overindulged. So this is a great framework. We do have a question for someone here in the audience, Dr. Nasir, where she talks about, and you let me know if you're able to help answer any of these questions. She said she cares for patients who are recovering from addiction. She says, can you give her some thoughts on insomnia management in patients who are using substances such as marijuana versus stimulants like cocaine or opioids and alcohol? She says she tends to use clonidine or trazodone or Seroquel for them. So you can kind of give the audience who are not breathed in this, we're like trazodone, clonidine, Seroquel. Oh, that's nice. But what are we talking about? So just kind of give them an idea of how one would treat someone who is having sleep issues when they're using substances.
Yes. Such a great question.
Some are legal and some are non-legal substances on the streets.
Yeah, absolutely. Hi, Dr. Nasir. So nice to see you here. And so the first thing I would think of is, is there some other sleep disorder that we're missing, like sleep apnea, right? So especially with patients who are using opioids, for example, that can induce central sleep apnea. So we want to be really careful about adding on another sleep aid that could be a respiratory depressant if they have undiagnosed or untreated, central or obstructive sleep apnea. Same thing goes with alcohol, right? So I would have a low threshold for testing those patients and getting a sleep study just to make sure we're not missing something with that regard, right? Then, of course, if we do need to use, a sleep aid, I think those are reasonable options. But also having a plan to, like whenever I prescribe a medication for sleep, I'm not anti-medications. So whenever I prescribe a medication for sleep, we talk a lot, me and the patient, we talk a lot about what's the game plan.
Yes.
How long are we going to use this for? What are the behavioral strategies we're going to implement to help you build your sleep confidence so you can eventually get off this medication? Now, of course, if you're treating an addiction, that's a big confounding factor for the behavioral piece, right? So the goal there is really going to be to get the addiction under control. You need to get them good sleep. So if you need to use a medication for support, absolutely do that. But then, once they're tapering off the medication, their whatever substance they're addicted to, they're going to have withdrawals, they're going to have more sleep disturbances. So can you really support them in the behavioral strategies that are going to give them the best outcomes, right? And again, thinking about restless leg, obstructive sleep apnea, circadian rhythm. Those are common sleep disorders that are often not being addressed. Hopefully that was helpful.
Oh, yeah, absolutely. So really, when we think about patients who are using substances, we have to keep in mind like how the substance is affecting their sleep drive in the first place. So are they going to have, like you said, the central sleep apnea? A lot of times, patients, we think of like the obstructive sleep apnea, which is what's going on here, but then we also have the part that's going on within the brain, which is not giving them that sleep drive within itself, right? So they're having issues with that. So we also have to keep in mind, as you're talking about, that you can use sleep aid to help, but the patient also is having an underlying issue, which is the addiction portion, right? So once you're having treating that part, we have to even keep in mind that there will be even an increase in probably a sleep abnormality during that. So you have to balance both of that as you are working with the patient to deal with the underlying issue of the addiction, and also dealing with the managing the sleep issue that comes along once you're treating the addiction. But caveat also is if the patient is not having any addiction issues and you're using aids to help them, then what's the game plan? Like this, the medication is a transition plan. It's not the end, right? So what is our end game plan? Okay, we're going to do this, but in addition to that, what else are we going to do on our ends as patients so that we can transition off of these sleep aids and still have great quality sleep without depending on said sleep aid? So I love it. And Dr. Nasir says that was very, very helpful. Very helpful. So thank you so much, Dr. Nishi. Alrighty. So we are now about to hit the fifth portion of what we need to think about as physicians. So go ahead.
Yeah, absolutely. And I'm just going to add one more thing in for Dr. Nasir, and, all your listeners, which is that, as we were saying, as physicians, we don't get a ton of training in sleep unless you go do fellowship. Even a 1-year fellowship it's not like you learn everything there is to know about sleep. But there are other supports available, right? So you as the doctor, sometimes we feel like we need to do everything and be everything to the patient, but use the resources that are available. Sleep coaches, there's apps, there's online programs, there's self-guided programs, there's group therapy programs, right? There's all of these resources available, and now with technology, they're much more accessible. So, do avail of those resources so you don't feel like you're carrying this whole thing on your shoulders. Now I have to fix their sleep too and treat their addiction, right? So there's a lot of support available.
Love it. Love it. Absolutely. So let's keep in mind and keep in the forefront of our mind that we do have support in the community at large to help with treating the sleep disorder, which is one of the additional things that is probably brought on your plate in addition to everything else you're trying to treat with your patients, but you might not have the time to do it all. So don't forget to use some of the resources out in the community. Love it. Alrighty, so what's our next one?
Yes. Okay, so tip number 5 is to
Mhm.
make your own sleep a priority,
Ah,
right?
yes, ma'am.
Prioritize
Yes.
rest. Yes.
Yes, we forget that part, right?
Yeah, absolutely. And again, going back to what we were just saying, as
Mhm.
physicians, we feel like we need to do everything, we need to be everything to everyone, and it's
Yeah.
simply not realistic. And we need to prioritize our own rest. Sleep is one form of rest. It's not the only form of rest.
Mhm.
Rest is the basis of all activity, right? So if we don't prioritize our own sleep, practice what we preach to our patients, we're not going to be able to really be there for them, be fully present for them. So it
Absolutely.
really goes back to that self-care piece.
Absolutely. And, the self care is the beginning of the care for the patient, right? So once you have poured into yourself, once you are at your optimal, once you are at your best, then you are able to give the best care to your patient. And it starts with sleep and you say rest. And so a restful sleep is important in order to be able to provide the care that you want to provide, because we know as physicians we kind of have this very high standards of how we want to provide care. We know how we want to provide it, and we know the level at which we want the patient to receive that care. Now, in order for that to happen, you need to be at your best. So yes, you need to be able to prioritize sleep within your own self in order to be at your best for your patients. So I love it. And you're right. You're right. A lot of us, we want to be all things for everyone, but sometimes we have to recognize we are unable to do so, not at the level that you truly, truly want to provide. So you need your own rest. I love it. All righty. Thank you for those 5 tips. But now I got to find out from you, have you yourself, with all that you have done, have you ever experienced burnout? And if you did, what did it look like?
Yeah, no, I love that you're asking this. And yeah, absolutely I've experienced burnout and I've experienced it many times in my life. I'm actually just coming off of a period of burnout, to be perfectly honest with you,
Yeah.
and this was in the past couple of months of just being overscheduled, right?
Mm,
And so I'm speaking from my own personal experience when I say, hey, we
yes.
need to prioritize rest. We need to say no to things because,
Yes.
I think we all fall into that trap, myself included, of
Mhm,
over scheduling ourselves, of saying yes to things when maybe we shouldn't be,
mhm.
and not making ourselves a priority. So yes, I've absolutely experienced burnout, and what it looks like for me is just a lot of fatigue.
Mhm.
It can look like problems with concentration,
Yes.
falling really behind on emails and things like this, and then feeling like I just can't get enough sleep. For me,
Yes.
I've always been on the other side of not insomnia, but hypersomnia, feeling
Mhm,
tired and sleepy and just feeling like, "Oh, I can't get enough rest." So that's
mhm,
how it shows up for me.
mhm.
And so for anyone listening, burnout shows up differently for everybody. And so it's
Absolutely.
important to know what the signs look like for you personally. But yeah, so I absolutely have experienced it. And what helps me is first just recognizing that, okay, I think I'm feeling burned out or I'm starting to get there. What do
Mhm,
I need to do to take care of myself now? And so for me, it's all about boundaries,
mhm.
kind of putting boundaries around my calendar, putting boundaries around my screen time. That's a big one for me. Having a cutoff time for my laptop. Okay, let me just get off. I'm not going to do, I could keep on going on Canva or, Google
Yes.
Docs, like working on stuff, my YouTube channel, whatever. So putting boundaries around that. And a big thing that helps me is to spend time in nature,
Mhm,
off screens. So I'm lucky to live in California. So going to the beach, going for hikes, even just
mhm.
sitting outside in the sunshine, all of those things are so restorative for me.
Love it. Love it. I love that you have talked about one of the best ways for you to really overcome burnout is to want to recognize when it's coming, and that you have your personal burnout signs and symptoms, right? And what you feel for you might not be what someone else will feel as burnout, but you recognize. So, hey, when the hypersomnia is coming back in, like, whoa, maybe something is happening. Why am I feeling like I just cannot get enough rest, right? My executive function is starting to deplete. I'm not able to function at the highest level, to make decisions at the highest level. I'm falling behind on important things that are important in my life that I normally would not fall behind upon. So you recognize, like, okay, well, it looks like this is creeping in. So one is your recognition, and then two, what you're doing about it. So two, you realize, okay, I need to take a step back and start putting some boundaries, which means that I need to start saying no to certain things. And also, you need to do things that restore back your energy, which for you is going out in nature. So, in addition to sleep, which of course is important, but restorative things for you is going out in nature, right? So, you're going to the beach, you're doing hikes, you're doing walks, you're being out in the sun, and just like getting back all of that energy that gets depleted during your burnout. So, I love it. I love all of this. Well, now you know I'm going to ask my fun question of the day. Alrighty, so if you weren't a doctor, or so interior designer, you weren't a linguistic. I have so many to pull off your table because you told me so much about yourself. You can engineer, or because that's an engineer, physician, or what is the third? Lawyer. Okay. Engineer, physician, or lawyer. Um, and you weren't this amazing psychiatrist, and you aren't out there restoring souls with integrative medicine or functional medicine. What would you be?
Yeah, I love that. I think I'd be doing something creative. I love making things beautiful, so probably something along the lines of interior design. I just love that. I could flip through interior design magazines all day, and, constant even when I was a kid, I was constantly rearranging my bedroom at home and, like,
Oh, you were one of
yeah.
those kids that you came in and everyone's like hitting their knee on this because it wasn't there yesterday.
Yeah, so I think I'd be doing something creative like that.
I love it. I love it. We have a couple interior designers in my utopia that I'm building in my mind of physicians. So another person to help to decorate the space and to do our interior designs in my utopia. Well, with this is such a wonderful conversation, Dr. Nishi Pohal. Thank you so much. Wait, Bhopal. I just like flipped your name. Dr. Nishi Bhopal. Thank you so much for joining us. But I know that there's some people that were joining online, that were listening, and they're watching this wonderful conversation. And they want to know, how can they contact you? How can they be part of your world? What do you have available for them? They've heard about, like I mentioned a little bit about a YouTube channel and so on. Tell us all about where they can find you.
Yes, so please come find me on YouTube. It's at IntraBalance. It's INTRA Balance. I've got lots more information on there for physicians about sleep medicine, and my email address is connected to that, so you can reach out to me and find me that way. And then for people who are looking for anxiety or sleep support in California, I have a private practice. It's called Pacific Integrative Psychiatry. And you can find us on our website at pacificintegrativepsych.com.
Love it, love it. So if you're in California, pacificintegrativepsych.com is where you are going to go. If you need help with anxiety, depression, or anything sleep related, so Dr. Nishi Bhopal is there for you. If you are a physician like me that's out here that is now super interested because we found out that beta blockers are causing issues. We found out that the vitamin D, yes, vitamin D plays a lot of role, but vitamin B12, B6, all of these things, magnesium. I only thought magnesium, if you had more of it, you're going to start having loose stools, but did not think about the issues that's going on with sleep. So for those of you who are like me, we have the IntraBalance YouTube website available to give us a little bit more insight into what's going on, all related to sleep. Well, do you have any last words for those of us before we leave this wonderful conversation?
Oh, well, Thank you so much for having me on your platform. This was really an honor and a delight to be here. And yeah, I mean, I guess my last words for everyone listening is take care of your sleep. Make
Hey.
rest a priority.
Make rest a priority. I love it. I love it. I love it. Now, I know those of you guys have been watching and you're like, OMG, Dr. Beckford. I said, I know. So, if you are looking for a dynamic speaker on stress management and burnout prevention, and we know that sleep is a huge part of that, for your next event, then I am she. Send me an email at drbeckford@yourcaringdocs.com and we'll see how we can make your next event the best event, especially if you're looking for someone on stress management and burnout prevention. Send me an email at drbeckford@yourcaringdocs.com, or you can contact me on yourcaringdocs.com, which is URCARINGDOCS.com. Now, I know if you missed part of this wonderful broadcast, you don't want to miss it. You might want to go to our website, which is yourcaringdocs.com, and select podcast. At that time, you're going to see Dr. Nishi's beautiful face. You just download that episode, send it to 10 of your friends who need sleep, and you know they need sleep because both of you guys are up at 2 a.m. saying like, oh my God, I need to sleep. Yes, you send it to all of your friends, and then you'll be able to capture everything that happened today, right? So with that, we're going to, again, thank Dr. Nishi Bhopal so much for stopping by on our Dr. Tamara Beckford show and dropping all of the knowledge about sleep. See you guys next time. Thank you so much again, Dr. Nishi. Bye-bye.